Good morning, dear learners, and welcome to the MOOC on rural development in India. And we are in week 10, and this is module 33, and this module is on major health issues in rural India. As you know, India remains a predominantly rural nation with 70% to 80% of its population residing in approximately 640,000 villages. Despite the nation's emergence as a global economic power, rural health outcomes continue to reflect a profound urban-rural divide characterized by disparities in infrastructure, personnel, and morbidity. Historically, the rural health landscape was neglected, leading to high maternal and infant mortality rates. To address these systemic failures, the Government of India launched the National Rural Health Mission, NRHM as you call it, in 2005, later expanded into the National Health Mission, NHM, in 2013, aiming to provide accessible and affordable care to vulnerable populations. While significant progress has been made, such as the eradication of polio and a sharp rise in institutional deliveries, rural India is currently navigating a complex epidemiological transition. Rural inhabitants are frequently caught in a medical poverty trap, where high out-of-pocket expenses for healthcare, often necessitated by a failure of public provisioning, lead to financial catastrophe. So in this module, we shall try to analyze the structural challenges in rural healthcare, the evolving disease burden, the state of reproductive and child health, and the precarious financial mechanisms that decline rural health today. And here in figure 1, it shows some of the recent progress the country has made in health indicators like IMR, NMR, underway mortality rate, as well as in out-of-pocket expenditures. So here we can see a declining trend in both IMR and also new mortality rate, NMR, and also under-5 mortality rate. Over the years, we see 2014 to 2020. Okay, and also here we see that out-of-pocket expenditure also has dropped during this period from 62.6% or around 63% to around 39%. The rural healthcare delivery system in India is structured as a hierarchical three-tier public network. At the base are the sub-centers, serving as the first contact point for the community. These are followed by primary health centers, which act as referral unit for 6 sub-centers, and community health centers, which provide specialist care at the block level. Despite the expansion of facilities under the NHM and NRHM, a chronic shortfall in infrastructure remains. As of 2022, there was an average population coverage gap where sub-centers serve 5,691 people, while the norm was for 5,000 people, and PHC served over 36,000 people, while the norm was for 30,000 people. So state level data reveals stark inequities. While the national average population served by a PHC is roughly over 33,000, this figure swells to 75,000 in Jharkhand and 49,000 in Bihar compared to just 9,000 in Mizoram and Arunachal Pradesh. And in table 1, we can see the standard national population norms followed for the establishment of health facilities against the actual average population served as of July 2022. So here in table, we can see the sub-centers. National norm is 5,000 for plain areas, and for hill areas it is 3,000. And actual rural average, as we see in 2022, was 5,691. And actual tribal average was in 2022 was 4,005. And primary health center, where the standard norm is 30,000 for plain areas, 20,000 for tribal or hill areas, and actual rural average was 36,000, over 36,000, and in hill or tribal areas it was over 26,500. And in case of community health center, the actual norm in plain areas was 1,20,000 population, and in tribal and hill areas it was 80,000. But in actuality we saw that in plain areas it was over 1,64,000, and in tribal and hill areas it was over 1,05,000. Now, despite the expansion of the facility network, a significant percentage of rural health centers lack the basic infrastructure required to meet quality standards. Adherence to Indian public health standards, the benchmark for quality, is alarmingly low. Now, data shown in table 2 indicates that only 3.45% of sub-centers, 13.16% of PSCs, and 8% of CACs meet these standards. I mean the IPHS standards, Indian Public Health Standards. Basic amenities are often absent. 28.4% of SCs operate without an electricity supply, and 18.4% lack a basic water connection. Furthermore, nearly half of the CACs in India function without a functional X-ray machine, severely limiting diagnostic capabilities for rural patients. Many facilities function in rented buildings, with nearly 9% of PSCs nationally operating in non-government accommodations. So here in table 2, we see these things. In case of sub-centers, PSCs and CSCs, we see quality norms is met only for 3.45% SCs, then only 13.16% in case of PSCs, and only 8% in case of CSCs, community health centers. Similarly, in government operating building, as you indicated, these that are here, and also without electricity, without regular water supply, with functional labor room, and with functional X-ray machine, we see this data for Indian public health facilities. Now, when we look at the human resource crisis, we will see that the most deliberating challenge is the catastrophic shortage of medical professionals. So, other than the public health infrastructure, public health facilities itself, the major challenge is the shortage of medical professionals. The shortage of qualified medical personnel, particularly specialists, remains one of the most critical barriers to effective service delivery. Now, from table 3, we can see that rural India possesses only 4.49 crore health workers per 10,000 population, significantly below WHO's recommendation of 23. While basic staff like auxiliary nurse, midwives, ANMs are often in surplus, 118% of requirements, there is a debilitating gap in specialists, doctors, surgeons, etc. Approximately 79.5% to 81.9% of specialist positions like surgeons, obstetricians, physicians, and pediatricians in CHCs are vacant. In states like Chhattisgarh, Arunachal Pradesh, and Uttar Pradesh, over 36% of PHCs function without a single doctor. This is a very alarming situation. The shortage is exacerbated by high rates of practitioner absenteeism, which can reach 45% in some regions, often attributed to poor infrastructure and lack of administrative accountability. The resulting lack of reliable public care shifts health-seeking behavior toward unqualified practitioners like quacks, who provide up to 40% of curative contacts in states like Orissa. This missing in action phenomenon of qualified staff forces rural patients to bypass primary care, leading to overcrowding in urban tertiary hospitals. And here with table 3, we can see the human resource crisis in rural public health facilities. For example, overall core health workers 4.49 per 10,000 population is available against the WHO recommendation of 23. Total specialist shortfall, as you see, 79.5% to 81.9%. This post is vacant. Surgeons, 83, more than over 83% vacancy is there. And pediatricians, it's over 81%. Gynecologists, it's over 74%. And practitioner absenteeism recorded as high as 45% in various public health facilities. Now, let us discuss some of the emerging health issues and disease burdens in rural India. Now, rural India is grappling with a dual disease burden, the persistence of traditional communicable diseases, and a rapid escalation in non-communicable diseases. So, looking at the burden of infectious diseases remain the leading cause of ailments in rural India, accounting for 35.9% of reported outpatient crises. Conditions such as malaria, cholera, tuberculosis, and diarrheal diseases are highly prevalent. Similarly, environmental factors are also primary drivers. Only 0.5% of the rural population enjoys basic sanitation facilities. In some surveyed regions, and nearly 50% of households in states like Odisha lack toilets. Vector-borne diseases like dengue and chikungunya are also becoming perennial in rural areas, with over 2 lakh cases of each reported nationally in 2023. Furthermore, the Northeast has emerged as a high-risk zone for HIV/AIDS, contributing a disproportionate share of India's cases. Now, when you look at the rise of NCDs, non-communicable diseases, and mental health, we see that non-communicable diseases now account for 63% of all deaths in India. This is highly alarming. Now, cardiovascular diseases have emerged as the second highest burden for both outpatient and inpatient care in rural areas. Lifestyle factors, including high rates of tobacco use affecting 23% of the rural adults, and physical inactivity are major contributors. And among the elderly, that is 60 years plus above people, 2/3 reported suffering from at least one chronic ailment by 2011. And interestingly, mental health is a critical yet neglected issue. While common mental disorders are less prevalent in rural areas than urban areas, the treatment gap in rural regions remains staggering, 70% to 92%, due to a lack of psychiatric infrastructure. And beliefs in cosmological powers as causes of illness often lead rural residents to seek witchcraft or traditional healers rather than psychiatric care. And when we look at the spatial disadvantages, we see that the rustic disadvantage is measured by distance from urban centers. Research indicates that villagers living more than 5 kilometers from a town have a 31% greater chance of contracting malaria and a 28% higher risk of cholera. Emergency cases such as spinal injuries or obstructed liver often prove fatal because the closest hospital may be hours away over unpaved roads. This geographical isolation ensures that new medical technology rarely reaches remote tribal belts like Gadchiroli in Maharashtra. Now, when we look at the reproductive and child health, we see that reproductive and child health is the cornerstone of India's rural health policy, primarily through the Janani Suraksha Yojana, JSY, a conditional cash transfer scheme. Now, India has successfully increased institutional delivery rates from 47% in 2007-8 to 88.6% in 2019-21. This is a remarkable assessment. However, deep-seated economic inequities persist. Women in the richest wealth quintile have an institutional delivery rate of 96.3% compared to only 61.5% for the poorest. And in rural areas, 87% of births are institutional, but many facilities lack quality care. In states like Rajasthan, studies reveal the rampant use of harmful irrational practices such as the misuse of intramuscular oxytocin to hasten labor and forceful fundal pressure, which increase the risk of birth trauma. And with regard to antenatal or postnatal care, we see that progress in antenatal care has been slow. Nationally, only 59% of women receive the recommended minimum of 4 ANC visits. The disparity is extreme. For example, in Tamil Nadu, 45% of women receive full ANC, whereas in Bihar, it is only 3%. Similarly, postnatal care is even more neglected. Only 27.1% of newborns receive health checkup within 48 hours, which is the most critical window for preventing neonatal mortality. Furthermore, only 67% of CHCs possess functional stabilization units for newborns, leaving many infants vulnerable in the first 28 days of life. Now, looking at the issue of child health and vaccination, here we see that child health is marred by malnutrition and vaccine-preventable diseases. National full immunization coverage stands at 76.4% according to NFHS 5 data, though administrative records claim 93.5%. Flagship programs like Mission Indradhanush have targeted dropped-out children in hard-to-reach areas, increasing coverage by 14.4%. However, spatial inequities remain. Children in remote villages living more than 5 kilometers from a town face a 23% higher chance of suffering from pneumonia. State-level infant mortality rate (IMR) highlight the divide. Kerala has an IMR of 12% per 1,000 births, live births, while Madhya Pradesh reaches 54. Nationally, the rural IMR is 31, which remains significantly higher than the urban IMR of 19 per 1,000 live births. And in table 4, we can see a comparative scenario in some of the RCS outcome indicators. So here in table 4, we see rural performance and urban performance and also the national average in indicators like institutional delivery, full immunization coverage, IMR, infant mortality rate, under 5 mortality rate, and ANC for 4+ visits. Now, with regard to the financing issues in healthcare provisioning, healthcare finance in India is characterized by critically low public spending and a regressive reliance on private financing. And when we look at the patterns of public spending, we see that the government allocates only 1.1% to 1.4% of India's GDP to public health, which is among the lowest rates globally. This translates to a per capita expenditure that varies widely by state. Sikkim spends 1,096 rupees per person, while Bihar spends only 83.90 rupees. Furthermore, benefit incidence analysis suggests that public spending is not sufficiently proper. For example, in rural areas, while outpatient care is somewhat proper, spending on inpatient care remains concentrated among the non-poor. And when we look at the out-of-pocket expenditure crisis in the country, we see here that owing to inadequate public provisioning, households bear 70% to 80% of health costs through out-of-pocket expenditure. And in states like Odisha, out-of-pocket expenditure finances 71.5% of total healthcare cost. This often necessitates distress financing, where families take high-interest loans or sell assets like livestock or land to pay for treatment. It is estimated that 63 million Indians are pushed into poverty annually due to this cost, with health shocks increasing the poverty ratio by 3.3 to 3.7 percentage points. And when we look at the private sector and insurance system, we see that the failure of the public system has led to the emergence of a dominant private sector, even in rural areas where 44% of residents now seek care at private hospitals. However, private care is significantly more expensive. The average cost per hospitalization is 2.29 to 3 times higher in private facilities than in government ones. Now, health insurance penetration remains extremely low. Only 2.2% of rural households have any coverage, leaving the vast majority exposed to financial ruin. In rural India, the concept of paying for unseen risk is culturally alien to many villagers who prefer paying only at the point of care. However, in certain rural pockets, like in Karnataka, Bihar, UP, the micro health insurance has made certain progress. And significantly, the Ayushman Bharat Prime Minister Jan Yojana scheme, which is basically non-subscription based, aims to provide insurance for the poorest 40%. Its effectiveness in rural regions is still being evaluated amidst concerns regarding missing providers and fragmented implementation. And from table 5, we can see status in some of the health financing indicators. And here it can be seen that the rural population face high financial risks due to low government investment and a heavy reliance on expensive private care. So here in table we see, supposing public spending on health is only 1.1 to 1.14%, 1.4% of GDP, and out-of-pocket expenditure, as we have already indicated, 70 to 80% of total healthcare costs. Medical impoverishment, as you already seen, 63 million Indians pushed into poverty annually because of catastrophic health cost. And in between private and public cost gap, we see that hospitalization costs are 2.29 to 3 times higher in private facilities. And only 2.2% of households have coverage in surveyed rural villages. They have the coverage of insurance schemes. Now, looking at the role of charitable and NGO-run hospitals, we have already seen that in India, the private sector dominates healthcare delivery through a profit-driven model concentrated in urban areas, offering advanced technology but at a high cost, averaging 2.29 to 3 times more expensive than the public alternatives. In contrast, charitable and NGO-run hospitals, not-for-profit hospitals, represent a small portion of service, accounting for approximately 2.7% of total hospitalizations and focus primarily on underserved rural populations. Thus, while private providers prioritize affluent demographics, charitable hospitals adhere to a near break-even philosophy, providing free or subsidized care based on a patient's ability to pay. Studies indicate that the charitable trust hospitals runs on a thin point of margin of plus minus 4%. Thus, their financial survival is precarious, governed by strict tax laws under Income Tax Act of 1961 that limits surpluses and often require them to cross-subsidize charity cases through higher fee private patient income. So consequently, while the private sector has transformed into a rapidly expanding industry, faith-based and charitable facilities have faced a historical decline in bed strength. So, to summarize, in this module we have discussed that rural India's health landscape is defined by a systemic mismatch between need and feed. While the National Health Mission or the NRHM have made notable strides in institutional delivery and infant survival, it has failed to meet core targets for specialist availability and universal infrastructure quality. Rural populations continue to suffer from a double disease burden, compounded by a spatial disadvantages and social stratification that leave scheduled caste and tribal communities particularly exposed. Achieving universal health coverage requires a paradigm shift away from fragmented, curative focused strategies toward a holistic primary healthcare model. This necessitates increasing public health spending to at least 2.5% of GDP, expanding the network of free diagnostics and transport services, and ensuring that all rural facilities meet the Indian public health standard norms. Furthermore, addressing the human resource crisis through strict accountability and incentives for rural postings is paramount. Without such structural reforms, quality healthcare will remain a luxury for the urban affluent, while the rural poor remain trapped in a cycle of debt and illness. Significantly, the rural patients report adverse perceptions in the quality of the public health infrastructure. This needs to be addressed at the earliest through appropriate policy measures and interventions. The overall discussion of this model has been summarily presented in figure 2. Okay, here we can see there is a 37% reduction in out-of-pocket spending over this period, and the digital health infrastructure is also surging ahead. Then declining child mortality rates we have seen, but the issues also like the low perception of rural services quality. People in rural areas perceive the public healthcare facilities services to be of low quality, and financial fragility of microinsurance, and also the charitable hospitals versus private insurance we have compared, and we have seen how these charitable hospitals are working on a thin margin of only plus and minus 4%. So these are the references, and thank you. And in the next module, we shall discuss about programs and policies in health in India. Thank you.